Pneumonia is more than a cough. It's an infection that makes breathing hard. On MaxMed channel, we'll break it down simply, step by step, so you can see how it works. Kindly like, subscribe, and share so others can learn from it too. Pneumonia is an acute infection of the lungs. It causes inflammation of the alveoli, which fill with fluid or pus, making it hard for oxygen to enter the bloodstream. Not all pneumonias are the same. To understand them, we must ask, what is the cause? Etiology, the study of causes, gives us the key. We have, number 1, community-acquired pneumonia, the most common type, often caused by Streptococcus pneumonia, Mycoplasma pneumonia, Haemophilus influenza, Staph aureus in decreasing order. 2. Hospital-acquired pneumonia. Develops 48 hours or more after admission, frequently due to resistant organisms like gram-negative bacilli, Pseudomonas, or methicillin-resistant Staphylococcus aureus. 3. Pneumonia in immunocompromised patients, seen in those with HIV, cancer therapy, or organ transplants. Opportunistic pathogens like Pneumocystis jirovecii, cytomegalovirus, Mycobacterium tuberculosis, or fungi are common. 4. Aspiration pneumonia, caused by inhalation of gastric contents or foreign material, either due to impaired consciousness, like epilepsy, alcohol, anesthesia, or impaired swallowing and gag reflexes, like dysphagia, stroke, Parkinson's disease, or esophageal conditions, like GERD, often involving anaerobic bacteria. Pneumonia is not a single moment of illness. It unfolds in stages, each with its own story inside the lungs. Stage 1, congestion. First 24 hours. The lungs become heavily congested due to vascular engorgement, increased blood flow, and accumulation of fluid rich in bacteria in the alveoli. There are few neutrophils or red blood cells, RBCs, at this early point. The lung appears red, heavy, and boggy. Symptoms may include mild fever, cough, and chest discomfort. Stage 2, red hepatization. Begins 2 to 3 days after onset, lasts 2 to 4 days. Massive numbers of RBCs, neutrophils, and fibrin fill the alveoli, creating a firm, liver-like, hepatized consistency. The lung appears red, consolidated, and airless due to the inflammatory exudate. This stage reflects intense acute inflammation. Symptoms often worsen: rust-colored sputum, worsening breathlessness, pleuritic chest pain. Stage 3, gray hepatization. Begins 4 to 6 days after onset or 2 to 3 days after red hepatization, lasts 4 to 8 days. RBCs begin to break down and disintegrate, while the fibrinopurulent exudate, fibrin and pus, persists. Hemosiderin from RBC breakdown and ongoing inflammation cause the lung to appear gray, gray-brown, or yellow-gray, still firm but less red. Macrophages start to appear. This is often an avascular phase. Symptoms may peak or begin to stabilize depending on the course. Stage 4, resolution. Begins around day 8 or later, can last 1 to 3 weeks or more. Enzymes from neutrophils and macrophages break down the exudate, which is cleared by coughing or lymphatic drainage. Macrophages phagocytose debris, and the alveolar architecture is gradually restored, without significant scarring in uncomplicated cases. The lung re-aerates, inflammation resolves, and normal function returns. Symptoms improve markedly with treatment, though full recovery can take time. Patients often experience cough, fever, chest pain, shortness of breath, fatigue, and loss of appetite. On examination, you may find the following signs. On inspection, findings of pneumonia commonly include signs of respiratory distress, such as rapid breathing, also called tachypnea, shallow breaths, and increased work of breathing, evidenced by the use of accessory muscle, nasal flaring. You may find signs of consolidation, that is when the alveoli become filled with fluid or pus, and these are: on palpation, the chest may expand less on the affected side. Also, the vibrations of speech, tactile vocal fremitus, feel stronger, carried more easily through fluid than air. On percussion, the resonant note of air is replaced by a dull thud. And on auscultation, the breath sounds shift, bronchial inequality, sometimes accompanied by fine crepitations. Even the patient's voice resonates louder. Vocal resonance is increased. But the danger is not only in the sounds we hear. Oxygen levels drop. A saturation below 92% is a red flag, signaling impaired gas exchange. The sputum tells its own story. Rusty or blood-stained sputum persisting over 24 hours is a classic sign of pneumonia, often pointing to bacterial infection. In children, the body speaks through different signals, a low, strained grunt with each breath, the chest wall pulling inward, indrawing, as the child struggles to breathe. These are urgent signs, demanding immediate attention. Bedside investigations. Basic observations. These include temperature, respiratory rate, oxygen saturation, heart rate, and blood pressure. They help assess severity, detect sepsis, and guide urgent management. Urine dipstick, used to rule out alternative diagnoses, example is UTI, and check for dehydration or renal involvement. 2. Blood tests. FBC, full blood count, looks for leukocytosis or neutrophilia, which support bacterial infection. UNEs, urea and electrolytes, assess hydration, renal function, and help calculate severity scores. For example, 𝙋𝙉𝙀𝙬𝙀 uses urea. CRP, C-reactive protein, a marker of inflammation. High levels support infection and help track response to treatment. LFTs, liver function tests, check for systemic involvement or baseline organ function before antibiotics. Glucose, important because infection can cause hyperglycemia, also relevant in diabetic patients. ABG, arterial blood gas, used when the patient is hypoxic or severely unwell to assess oxygenation and acid-base status. Atypical serology, detects organisms like Mycoplasma, Chlamydophila, or Legionella, which do not show on routine cultures. 3. Microbiology. Sputum culture and blood cultures. Identify the causative organism and guide targeted antibiotic therapy. Urine antigens. Detect Legionella and Streptococcus pneumoniae antigens, useful for atypical or severe pneumonia. Throat swab. Used when viral causes are suspected, for example influenza, since viral pneumonia can mimic bacterial disease. 4. Chest X-ray. When a chest X-ray shows consolidation, it is considered a key diagnostic finding. A chest X-ray is the key test to confirm pneumonia, showing consolidation or infiltrates in the lung fields. It also helps rule out other causes like heart failure or malignancy. 𝙋𝙉𝙀𝙬𝙀, severity score for community-acquired pneumonia, 𝙋𝙉𝙀𝙀, for predicting mortality and for assessment of severity. 1 point each of the following factors: confusion, restlessness, or excessive drowsiness, BUN greater than 7 millimoles per liter, respiratory rate greater than 30 per minute in adults and greater than 50 per minute in children, low BP less than 90/50, patient at extremes of age, less than 5 years, greater than 65 years. Total the scores obtained. 0 to 1, consider home treatment, OPD. 2 to 3, consider short inpatient hospitalization, detain. Greater than 3, admit and consider intensive care. Any of the following factors in addition warrants hospitalization: coexisting disease like heart failure, renal disease, chronic lung disease, extensive disease, multiple lobes affected, low oxygen saturation, less than 92%, severe tachycardia. Pneumonia begins when pathogens or irritants enter the lower respiratory tract, most commonly through inhalation of airborne droplets, aspiration of oropharyngeal secretions, or hematogenous spread from a systemic infection. Pneumonia develops when the normal respiratory defenses, such as mucociliary clearance, alveolar macrophages, and immunoglobulins, IgA, IgG, are impaired or overwhelmed by factors like smoking, chronic illness, or immunosuppression, allowing pathogens to colonize the alveoli. In pneumonia, pathogens activate alveolar macrophages to release cytokines such as interleukin-1 and tumor necrosis factor alpha, which recruit neutrophils and other immune cells, leading to alveolar inflammation and capillary leakage. Plasma, fibrin, and immune cells exude into the alveoli, which then become filled with pus, fluid, and cellular debris. This consolidation reduces ventilation and impairs gas exchange. These causes systemic effects which include hypoxemia from impaired oxygen diffusion, increased respiratory rate and effort, and fever with a systemic inflammatory response. In summary, the pathophysiology of pneumonia follows a sequence in which pathogen entry and host defense failure trigger inflammation and alveolar exudation, progressing to consolidation that impairs gas exchange and ultimately produces clinical symptoms such as fever, cough, and dyspnea. General principles of treatment. Identify the cause: bacterial, viral, fungal, aspiration. Support oxygenation and ventilation. Control infection with appropriate antimicrobials. Relieve symptoms and prevent complications. Antimicrobial therapy. Bacterial pneumonia, antibiotics. Choice depends on age, comorbidities, severity, and local resistance patterns. For outpatient, give amoxicillin, doxycycline, or macrolides, for example, azithromycin. For inpatient, beta-lactamase inhibitors plus macrolide, or respiratory fluoroquinolone, or cephalosporins. For viral pneumonia, supportive care, antivirals only for specific viruses, oseltamivir for influenza. For fungal pneumonia, antifungal agents, amphotericin B, fluconazole. In aspiration pneumonia, broad-spectrum antibiotics are used because aspiration often involves mixed flora, aerobic plus anaerobic organisms. Common regimens: ampicillin sulbactam IV or amoxicillin clavulanate oral. Alternatives: clindamycin, carbapenems, or metronidazole combined with a cephalosporin. For atypical pneumonia, we use clarithromycin for Legionella, tetracycline for chlamydia, high-dose cotrimoxazole for Pneumocystis jirovecii. Supportive care: oxygen therapy for hypoxemia, IV fluids for dehydration, antipyretics, paracetamol or acetaminophen for fever, analgesics for chest pain, nutritional support. Pneumonia doesn't just stay in the lungs. Sometimes it triggers sepsis. And beyond fever and cough, some patients even develop confusion or altered mental status. So here's the challenge. Why can sepsis develop even when the infection is confined to the lungs? And why can pneumonia cause confusion in the first place? Share your answers in the comment section. I'd love to see your answers. That's the big picture of pneumonia. Stay sharp, keep learning, and join me in the next lesson here at 𝙋𝙉𝙀𝙐𝙬𝙼.